Okay, you guys want to go over an upper extremity case study. So running through my memory bank of people that I saw last week, and this one pops in my head. So we'll go eval with an individual who is right hand dominant. He's in his mid 50s, I believe, plays a lot of racquetball, plays a little bit of pickleball, having problems with elbow symptoms. He's been a patient before, haven't seen him for probably 3 or 4 years. I think last time he came in, it was more like low back hip stuff, but still very active back then. So this isn't somebody who's coming off of not being active and then all of a sudden throwing a bunch of stuff at it. So that's not this guy's situation. All right, so I want you to think about, as we go through this, and right now, think about you have this guy show up in your clinic. He's complaining about right elbow pain, kind of like posterior, so not really medial lateral, posterior elbow pain with tightness. He calls it tightness in the elbow. Did have, way back when I saw him a couple of years ago, did have some issues with some shoulder things, but that was mostly stemming from low back, hip type stuff. Mostly sedentary job, nothing, not desk work or anything, but not repetitive overhead lifting or reaching or anything upper extremity wise, to think about. So now think about what you would want to assess with this guy. I'm going to walk through what I did. And if you've been watching these, you already know exactly what I'm going to say. I'm going to have him take off his shoes and I'm going to assess everything. So watch him walk, watch him squat, single leg squat, touch toes, trunk rotation, shoulder flexion, abduction, internal rotation, external rotation, cervical flexion, extension, rotation. Check all that stuff. And when he's complaining of, he complains of shoulder tightness at about 90 to 100 of abduction, 90 to 100 of flexion, a little bit of lack of range of motion, right shoulder versus left shoulder, terminal end range of motion, flexion, extension in the shoulder. Cervical rotation is tight bilaterally, extension, flexion fine, tight with toe touch, unstable with single leg squat. And when we check elbows, so we check elbow extension, elbow flexion, supination, pronation, grip strength. He has no complaint of any kind of lateral or medial epicondylitis pain with any kind of resisted supination, pronation, grip, no problem, extending fingers, no problem. He does have and lacks active and passive elbow extension. Active is probably 10 degrees, passive is probably 3-4 degrees of extension. So we've got an elbow issue there. Looks like a gunstock deformity, but when I compare it to his uninvolved, it's pretty similar. Okay, so we've got a guy who's got just genetic gunstock deformity, minor gunstock deformity, lacking elbow extension. When I asked him, had he had any previous elbow fractures or dislocations, denies anything there. When I asked him, do you notice that you can't get your elbow straight? And he said, well, not until you just pointed it out right now. So I have no idea if this is normal or if this is abnormal. So when I do test him, he does have kind of more of a, it's kind of funky. It's kind of a hard end feel, but then he also explains that he's got distal bicep tightness when I push him into full elbow extension passively. All right, so there's your guy. So what are we gonna start with? So if you've been through the shift, you know that I'm going to start with feet, or legs, and I'm gonna work my way up because I already know he's got issues here. I need to know what he's got going down below. And I also know that he's got previous history of lumbar, trunk, hip stuff that caused some shoulder things. So I want to see if this is something that's stemming from below that he's making up for here. So go through that, nothing too terrible, run-of-the-mill, lower extremity, trunk stuff. Get up to the shoulder, and he has normal passive range of motion in the shoulder. No real issues there. A little bit more external than internal rotation like you would see in a regular overhead athlete. Nothing groundbreaking there. But when I start checking NFTs, he fails upper trap, middle trap, lower trap, pec major, posterior middle delt, upper trap for cervical tests, Does not fail rotator cuff stuff. So supraspinatus, infraspinatus, subscap is all good. But remember, he failed delts, he failed middle trap, lower trap, upper trap, pec major. Also, when we did a screen, he complained of horizontal adduction stretching in the posterior delt. So if you understand how the law of reciprocal inhibition works, which they didn't teach you in school, but you'll learn in the shift, when you go to horizontal adduction and you have tightness back here, that's telling you check pec major. Pec major is not pulling him across. Posterior delt, tricep is trying to resist because they're not getting the reciprocal response. And now you have shoulder tightness with adduction, horizontal adduction, which does not mean you tell them, oh, well, just go do this, because now you just made everything worse. So that's why you never stretch. Tight muscles are telling you there's inhibition somewhere. Since you have a degree, 7 years of school, you should be able to figure this out without saying something completely overly basic and fundamentally wrong, which would be stretch the tight thing. The tight thing is not the problem. Okay, so get through all that, take them through, feels much better. Everything looks pretty decent. Now we get to long-headed bicep, long-headed tricep, biceps, triceps, forearm supination, pronation, flexion, extension, flexion wad, flexor wad, extensor wad, get into that. And he doesn't have a whole lot going on with any of that. So this is a shoulder patient. This is not an elbow patient, but it's an elbow patient who possibly could have something going on in the joint space, which is why I get that funky hard end feel before we get to full extension, which could be from the deformity that he has genetically. And he's doing a lot of repetitive stuff with the sports that he has chosen to play. So now think of, we got through assessment. We got through gross assessment with the screen. We've got through individual neuromuscular assessment of all the muscles. Got all of those that are inhibited, reverse, so they're not facilitated. So now what are we gonna do? We're gonna get them off the table. We're gonna go through our functional screen again and see if range of motion quality and gross motion and strength and stability looks better than it did before, which it does. And he says, wow, I didn't know that my shoulder was bothering me that much, but now that I can feel what normal feels like, that's a heck of a lot better. So he just threw out neck, cervical rotation, better. All active range of motion, no more stiff, painful arc at 90 to 100 with flexion and abduction, full internal, external rotation, no problems getting back here. When we did this before, getting here, he didn't complain of shoulder stuff, he complained of elbow stuff. So now when we get here, he goes even further and he has no shoulder complaint, he has no elbow complaint. So the only thing that remains relatively similar to the pre-screen is his passive extension. Now when I do get him to extension and feel that hard and feel, he's not feeling distal bicep tightness. All right. So now what is his home exercise program going to be? It's going to be elbow stuff. I'm going to throw a little bit in there just to move elbow and see if we can get more range of motion out of it. But we're going to do trunk things. We're going to do lunge walk, crossover walk, shocker. We're going to do band things. Are we going to do internal, external rotation down here like old school PT does for absolutely no reason? I don't understand why as physical therapists we're doing internal, external rotation down here with a TheraBand with somebody who is an overhead athlete. When do we ever do anything down here? Never. So why are we giving patients exercise there? I have no idea. All you're doing is burning up one of the heads of the subscap and infraspinatus, depending on which way you're going. Don't do that. They should be coming out. They should be rotating around their humerus. They should be going, and then if you're getting through here, if you've got an upper extremity athlete, now we should be taking them up here and doing the same thing up here because that's the position that they play in. Okay? So remember, your infraspinatus and your subscap is a fan shape, which means when you go through shoulder flexion and abduction, those heads of the infraspinatus and subscap are going to take over and hand off to the next head as they get up here, which means if you don't exercise them here and you only tell them to keep their elbow on their side and do this stupid thing, all you're gonna do is burn them up and one head, and it's not even the head that they have problems with. Now they have a problem with it, what they didn't have a problem with. I have no idea why we learned that in school. So that's what we're gonna give to him. He did come back for his follow-up. He was on the other therapist schedule, but he is, I did tell him, you know, it might be a good idea to get imaging and just make sure we're not dealing with something that's in the way, that we're obviously, if he's got a bony or a calcification or something in the joint space, we're not gonna get past that. We got a bunch of stuff here and in this trunk that we can work with, that we're gonna work with. But if there's something in the way of the joint itself in the elbow, might not get full elbow extension, which doesn't mean that he can't play, doesn't mean that he can't be pain-free, doesn't mean that he can't be full range of motion and normal strength. It just means that we're going to have to stay on top of that. So as he starts to use less and less extension, just because subconsciously he's staying away from it, that we don't start the snowball effect where now this has less range of motion, this tries to make up for it with his, which is why he had all of the problems that he had here. So remember, start proximal, big muscles, move distal, small muscles, even if somebody's coming in with a wrist. If somebody comes in with a wrist problem, I'm never going to go look at their wrist first. I know that the wrist depends on the elbow, and the elbow depends on the shoulder, and the shoulder just depends on the spine. Spine depends on the trunk depends on the feet. So I'm gonna go reverse engineer everything because I already know there's symptoms here. My job isn't to cover up the symptoms. My job is to figure out what else is feeding into this to make them compensate to use this or this too much, because this or this is what is inhibited or where the problem is. Okay, so hopefully that made sense. Got questions, comments, post them below. And if there's another body part injury case study idea that you have, send that to me. That's where I got this idea, was from somebody who commented on the last one. So let me know if there's another case study that you want to see. Talk to you later.